Hi friends, I'm Dr. Jeevadram. Today I will discuss about depression and its treatment. Introduction to depression. Depression is affective disorders. What are affective disorders? These are mental illnesses characterized by pathological changes in mood. What is depression? It is pathologically depressed mood. Definition of depression by WHO. It is common mental disorder that presents with depressed mood, loss of interest or pleasure, feelings of guilt or low self-worth, disturbed sleep or appetite, low energy and poor concentration. Types of depression. Major depressive disorder, recurrence of long episodes of low moods or one extended episode that seems to be never ending. Atypical depression, postpartum depression, catatonic depression, seasonal affective disorder, melancholic depression, manic depression, bipolar disorder, 4 episodes of bipolar disorder, depressive episode, manic episodes, hypomanic episode, mixed mood states. Dysthymic depression, lasts a long time but involves less severe symptoms, lead a normal life but we may not be functioning well or feeling good. Situational depression, psychotic depression, endogenous depression. Epidemiology. Globally, more than 350 million people of all ages suffer from depression. For the age group 15 to 45, major depression is the leading cause of disability in the US. Women are nearly twice as likely to suffer from a major depressive disorder than men are. With age, the symptoms of depression become even more severe. About 30% of people with depressive illnesses attempt suicide. Etiology of depression. Genetic cause, environmental factors, biochemical factors. Biochemical theory of depression postulates a deficiency of neurotransmitters in certain areas of the brain: noradrenaline, serotonin, and dopamine. Dopaminergic activity reduced in case of depression or activity in mania. Endocrine factors, hypothyroidism, Cushing's syndrome, etc. Abuse of drugs or alcohol, hormone level changes, physical illness and side effects of medications. Drugs, analgesics, antidepressants, antihypertensives, anticonvulsants, benzodiazepine withdrawal, antipsychotics. Physical illness, viral illness, carcinoma, neurological disorders, thyroid disease, multiple sclerosis, pernicious anemia, diabetes, systematic lupus erythematosus, Addison's disease. Pathophysiology of depression, the biogenic amine hypothesis, the receptor sensitivity hypothesis, the serotonin-only hypothesis, the permissive hypothesis, the electrolyte membrane hypothesis, the neuroendocrine hypothesis. The biogenic amine hypothesis, caused by a deficiency of monoamines, particularly noradrenaline and serotonin, can't explain the delay in time of onset of clinical relief of depression of up to 6 to 8 weeks. The receptor sensitivity hypothesis. Depression is the result of pathological alteration, supersensitivity, and upregulation in receptor sites. Tricyclic antidepressants are monoamine oxidase inhibitors. Causes desensitization, the uncoupling of receptor sites, and possibly downregulation, a decrease in the number of receptor sites. The serotonin-only hypothesis emphasizes the role of serotonin in depression and downplays noradrenaline, but the serotonin-only theory has shortcomings. It does not explain why there is a delay in onset of clinical relief. It does not explain the role of NA in depression. The permissive hypothesis, the control of emotional behavior, results from a balance between noradrenaline and serotonin. If serotonin and noradrenaline falls to abnormally low levels, the patient becomes depressed. If the level of serotonin falls and the level of noradrenaline becomes abnormally high, the patient becomes manic. The electrolyte membrane hypothesis. Hypocalcemia may be associated with mania. Hypercalcemia is associated with depression. The neuroendocrine hypothesis. Pathological mood states are explained or contributed to by altered endocrine function. Clinical manifestations. Thinking is pessimistic and in some cases suicidal. In severe cases, psychotic symptoms such as hallucinations or delusions may be present. Insomnia or hypersomnia, libido, weight loss, loss of appetite. Intellectual or cognitive symptoms include a decreased ability to concentrate, slowed thinking, and a poor memory for recent events. Diagnosis. ICD-10 diagnostic criteria for a depressive episode. WHO. Usual symptoms: depressed mood, loss of interest and enjoyment, reduced energy leading to increased fatigability and diminished activity. Common symptoms: reduced concentration and attention, reduced self-esteem and self-confidence, ideas of guilt and unworthiness, bleak and pessimistic views of future, ideas or acts of self-harm or suicide, disturbed sleep, diminished appetite. Mild depressive episode. For at least 2 weeks, at least 2 of the usual symptoms of a depressive episode plus at least 2 common symptoms. Moderate depressive episode. For at least 2 weeks, at least 2 or 3 of the usual symptoms of a depressive episode plus at least 3 of the common symptoms. Severe depressive episode. For at least 2 weeks, all 3 of the usual symptoms of a depressive episode plus at least 4 of the common symptoms, some of which should be of severe intensity. Investigations. Rating scales, Beck Depression Inventory, Hamilton Depression Rating Scale, dexamethasone suppression test. Treatment of depression: antidepressants, monoamine oxidase inhibitors, irreversible monoamine oxidase inhibitors, isocarboxazide, iproniazid, phenelzine, and phenylcypromine, reversible monoamine oxidase inhibitors, moclobemide, and chlorgeline, tricyclic antidepressants, NA and 5-HT reuptake inhibitors, imipramine, amitriptyline, doxepin, dothepin, and clomipramine, NA reuptake inhibitors, deciimipramine, nortriptyline, amoxapine. Selective serotonin reuptake inhibitors: fluoxetine, fluvoxamine, sertraline, and citalopram. Atypical antidepressants: trazodone, mianserin, metazapine, venlafaxine, duloxetine, bupropion, and tianeptine. Non-pharmacologic therapy: lifestyle changes, stress reduction, social support, sleep, psychotherapy, cognitive behavioral therapy, interpersonal therapy, psychodynamic therapy. Electroconvulsive therapy (ECT), safe and effective for all types of major depressive disorder. ADR, cognitive dysfunction, cardiovascular dysfunction, prolonged apnea, etc. Conclusion: affective disorders remain one of the most commonly occurring mental illnesses in adults. It is often undiagnosed and untreated. Both pharmacological and non-pharmacological interventions act as cornerstone in the treatment of affective disorders. Pharmacists play an important role in accomplishing these treatment goals.